just to kind of set the tone a bit about this this topic. So as we know, women's health is quite a big subject. It really goes from all of the period tracker, all the way from the fertility, postpartum, menopause, et cetera, right? It's a really, really big area. And above it all, this is really about a topic that covers half of the planet. So well, it was reported that last year we had over 3.8 billion women on the planet. So it's really a demographic that represents 49.6% of the global population. So it's also a very interesting space in Asia because of the demographic boom that we had in recent years. So women's health is a very, very important subject. And I think that there is many areas that we should tackle and look at all of the challenges that we have in this particular area. So, I mean, without any further ado, we have a great panel, and I will ask all of my panelists to maybe take a few minutes to explain to us who you are, your venture, and also give us maybe that little moment where you decided to create your own digital health solution for this specific area. So I will start with woman first. Anda, over to you. Welcome.
Okay. Hi, I'm Anda Sapardan from Sehati Telectg. Before I started Sehati Telectg in 2016, I have more than 12 years of experiences in healthcare industry, hospital management to be exact, and I have a strong family background in healthcare industry in Indonesia. Actually, the passion started 27 years ago when I gave birth to my firstborn at a very young age. I was privileged with all the means that I have, that I was able to have a happy and healthy pregnancy, which actually is the right of every woman in the world. Then I'm in 2000, actually I met Dr. Ari way before 2016, but in 2016, together with Dr. Ari and Abraham Auzan, we share the same vision and passion and agree that utilizing technology will enable preventive, promotive, and standardized primary women and children health to be delivered more effectively, equally, and affordably. Sehati Telectg is a start, actually it's just the foundation of our aim to assist in changing the healthcare business paradigm, how healthcare delivery is being provided. Well, Sehati Telectg itself is an integrated telemedicine-based platform that consists of application for midwives and mothers, dashboard for analytic, telemedicine-based portable cardiotocography or telectg, and consultation center where midwife can consult with OBGYN for CTG interpretation. The solution is initially designed to assist in lowering maternal mortality rate and stunting intrauterine through early detection of risk factors and become one of the solutions to address the challenges of lack of access to healthcare facilities, failure to detect risk factors, and disparity in healthcare workers, either it's the competency, numbers, or the distribution. Besides health tech innovation, we also include empowerment. So specifically women empowerment for the impact to be raised optimally. I think that's the introduction from me.
Thank you very much. And just before I continue, how old is Telectg right now? You've been in business for how many years?
4 years. It takes us 2 years for the research and to get the marketing license from the government. So it can only be marketed by the early 2019.
Fantastic. Thank you so much.
Thank you.
Okay, now maybe I'll move to Amrish. Just looking at my screen just like that. Hi, how are you?
Doing well. Thanks for inviting me, Helene.
You're welcome. So same for you. Can you give us an introduction about yourself, your venture, and really when and how this came about?
So, I mean, it all started in NTU when I was a graduate student, and no offense to all the academics out there, but it really just got a bit too much. You keep publishing and there's nothing at the end of it, I would say, especially in the field like engineering and health science where there's real clinical application. And I think that's where we saw the potential to really spin off and make real difference in people's lives. And so after recovering from academia, I think we looked at how we could use our skills, particularly in the field of mobile health. And what I mean by that is how can we use sensors, algorithms, processing to enable data collection outside of the hospital where patients spend 99% of their time. And if we want truly personalized healthcare, we want to truly lower costs, improve healthcare, we have to engage the patient as a participant in their healthcare. And the way to do that, we believe, is through mobile health and providing more people access to healthcare. So, I mean, we started off a bit in cardiology, but we pivoted into fetal monitoring because for us, it was just sort of the perfect blend of a good social cause. You know, women are largely underserved when it comes to technology. I think a lot of the technologies haven't evolved for a long time. And there was a good business case in that more people in developing and developed countries are looking to spend in their healthcare. And lastly, it was a cool technical problem. How do we actually how do we enable clinicians to collect useful data outside of the hospital? It was a cool engineering problem. It was a cool usability problem. And for us, that really set the tone of what is a useful product, right? Those three things really come together in what is a useful product. And so, I mean, this started really making sense when my wife and I had a kid a few years ago, and she started going to hospital every day towards the last part of her pregnancy for CTG monitoring. And I figured there has to be a better way to do this. I mean, both of us were spending 3 to 4 hours in a hospital every day for 2-3 weeks. And every day the results came back, it's perfectly fine, you know, you're free to go home. So it was a very puzzling experience, even for someone in the field. Just going through it personally really helps build that this really is a problem, you know, this is something that we need to solve. And understanding the journey from pregnancy into what is actually not a disease to how can we enable proper data collection so that fetuses can be monitored properly, moms can be monitored properly. And I think that's the most important thing, keeping women and children safe. And once we build that clinical value through a suite of monitoring that allows for risk stratification, that allows for eventually going into fetal monitoring for high-risk pregnancies, that clinical value is really what drives us. And it doesn't just stop there. It goes on to the analytics. It goes on to research and how we can actually detect fetal distress better, not just replicate what's done, but how do we do it better? And so that's a little bit about the journey and our FEMOM platform, which is a full fetal and maternal monitoring platform for low risk all the way to high risk women.
Fantastic. We will dive into that just in a few more minutes, because I know that's very important to try and understand everything that you do. Just for the sake of our participant, how old is your venture now? This journey has
we've been active for 4.5 years at this point. And so we are still pre-regulatory, and we'll be applying for regulatory this year, regulatory clearance in US, Australia, and in Europe.
Fantastic. Thank you. Before we move to Harpreet, I'm just telling the person you can actually ask your questions in the Q&A section. Don't hesitate, and we will be able to really go through some of these question and answers at the end. Thank you so much. So Harpreet, now your turn, please. Welcome, and thank you so much for joining us. Can you tell us a bit about your venture, how this all started?
Thank you, Helene, for inviting me. So I'm as a background engineer. I did my PhD in biomedical engineering, and I've been working in healthcare for close to 19 years. And primarily, I worked in senior leadership roles across different healthcare companies before I decided to move back from US to India to extend family and to raise kids. And 9 years back, I was blessed with twins, preterm babies, 27 weekers. And that was kind of a moment of reckoning for me, where we realized that the babies can be born before term. So there was no knowledge of that, you can have babies who can be as small as 1,000 grams. And it was very stressful. At the same time, I will say very difficult experience as parents. And both of us, me and Ravneet, who co-founded this company, we were kind of the whole trauma of staying in the NICU and going through that experience was, I will say, life-changing. So unfortunately, one of the kids didn't survive, and we lost after a week. And till that point, as an engineer, the goal was to just build good products. So one of the product I built prior to that experience was acquired by Philips. So I had background in healthcare, and I was doing my work, but this kind of gave a vision that let's do something where we can, as Amrish said, help the society, do something which is more useful. So we started with child health imprints, initially in India, and the aim was there are too many devices in neonatal intensive care unit, but very few doctors to interpret and make information out of it. And as per WHO, the human errors are the major cause of death. So out of 150 million babies born globally every year, 15 million of them are preterm. So 1 in 10 kids are preterm, and we lose close to 3 million of those in first 27 days of life. So that was realizing that it's so close to you and you're not aware about it. And once you go through that experience, you a lot of people come to you that, I also had a preterm baby, I also went through this journey. And so we decided, okay, we will come up with a solution where we can combine all this data, use the hardware capabilities to integrate all the data available, use the software capability to bridge with EMRs, and then use analytics to provide that golden hour opportunity to doctors to save these babies because they have absolutely no immunity. And so we started in 2016, and then we were funded by Enterprise Singapore government in 2018, where we moved to Singapore and became a Singapore company. So technically we are a 3-year-old company, but practically we are 5-year-old. So we are right now running in 27 different NICUs, catering to almost 75,000 lives. And the goal has been still, the passion from day one, and still trying to figure out if we can save that one life, because it's a very hard problem to solve. And from a regulatory point, we are HSA, FDA, and MFDS approved. So we are trying hard to create that impact. But this is a very hard problem. I mean, the world is this mortality in neonatal space is a big challenge, especially for developing countries.
Thank you so much for sharing your story. Unfortunately, there's a part that is very sad, and I think that the work that you guys are all doing will certainly change some of these reality that some parents have been through, like you. Very, very sorry to hear that. That actually bring us to our second question. And we could probably start with, again, that kind of same order. So I feel that all of you, right, there is a story in the back of what you guys have been through, what you guys have been doing, and say you gotta have to change the status quo of what we are going through as a parent. But tell me, what do you think are some of the major pain points, especially in that area of women's health? Enda, do you want to start on this and give us your thoughts?
Yes. Actually, the impact if mothers die, it's not just, it's the social impact, it's the economical impacts. That's why we want to tackle the pain point of maternal mortality rate first. Because if one mother's die, actually women is the foundation of a household. I'm really sorry, man, but that's the truth. I mean, if the mothers is not, it's not there, then it's I don't know, like in Indonesia, in West Java and everything, the children are not yet managed well. So actually, what we are aiming is for better quality of Indonesia future generation, and that has a lot to do with the first 1,000 days of life, and women are the key factors in that milestone. So I think that's it from me.
And in terms, I think that in Indonesia, right, one of the I guess certainly one of the pain points, all of the remote area, right, that you have just physically because of your, the geography. So was that also something that was part of the pain points that you were seeing, and that you said, okay, we have to change, right, the reality that we are facing when it comes to caring with our patients?
Actually, the maternal mortality and neonatal mortality, as well as stunting intrauterine, it can be managed if we can detect risk factors very early. So preventive action can be taken. And technology will help that to be done from remote area. What the pain point that we are aiming to tackle is with the technology, with the platform and solution of Sehati Tele-CTG, we can actually detect risk factors very early, because the application has an algorithm that can detect 53 risk factors that can be utilized to do predictive analysis, demand planning, what the condition of the mothers, and for prompt intervention to be taken, actually. And then with the solution, with only 4,400 obstetrician and gynecologists in Indonesia, across Indonesia, and there are more than almost 800,000 midwives, we can empower midwives with the solution, give them the access to operate hospital standardized tools to help the fetal well-being detection, as well as to collect the data, to cohort data. So as well as to answer the problems of discrepancy, the competence, because not every midwife has the same competency, but with this technology, it will be standardized, because you have to put in all the requirement examination through the application. Otherwise, it will not give you the results for optimum preventive and promotive actions. We have helped. We have reduced the numbers of maternal death in Kupang region by 71% within 1 year. And then we have increased through early detection, we can increase the managed early referral, because with managed complication, by research, it could reduce the number of maternal mortality rate by 78%.
Wow. And all that thought, because I would like to come back on that point. Those data points are very impressive, and I would love for all of us to be able to dive into some numbers. Yeah. Very, very good. Thank you so much. Amrish, same question. So, I mean, we understand your journey as a father and what you've been through, but what are also the other kind of pain points that you were seeing, except for the long waits? I'm sure there was just not that, but that you still see today, probably, that you saw and you still see. What are the pain points, especially in that specific area that you are operating in?
Yeah, and I think I can boil it down to three things, right? It's about access to healthcare, consistency in healthcare, and continuity of healthcare. And I think access to healthcare is a tremendous issue, both developing and in developed countries. And I think what COVID has actually brought about is the fact that we cannot take access to care for granted, even in developed countries. In several countries around the world, pregnancy visits are being reduced to the bare minimum under the SDG goals. That's just, you can't ask a pregnant woman to hold on, right? She has to deliver the baby, right? It's hang on till we get the next slot. We have to be able to provide that monitoring and the safety for the mother and baby, despite scenarios like this where there's limited access to hospitals. And I think that's vitally important both in developing and in developed countries. Where developing, there's even a shortage of clinics in good times. Like what Anders mentioned, I think it was such a beautiful point that technology can really help fill that gap. And that's what we're looking to provide. In developed countries, how do we allow women to make that choice where now they have an additional option of monitoring themselves at home, so to ensure the safety of themselves and their baby. and how do doctors have those data points so that they know their patient's doing well. Secondly, on the consistency of care, current antenatal monitoring standards are extremely gray. So they're not well defined, and they need to be better. And this has led to a big problem of escalation of emergencies. This has led to a big problem of wrongly identifying women who doctors think are having emergencies. And this is a problem around the world. I think you go to a first world hospital, you go to a hospital in the middle of nowhere. This is going to be a problem. The senior consultants know very well what they're doing, but they're not reading every trace. The junior doctors are always going to have to learn, but do we really want to build a system where a junior doctor has to take years to learn what could actually be better performed by digital analysis? Or is that really what we want doctors to be doing, to be able to read between the lines? And you're going down to midwives, nurses, anyone who provides care. So the consistency of care, and when do we escalate? When is this an emergency? When is this not an emergency? High rates of C-sections in developed countries due to sort of phantom emergencies, as well as women not being delivered in time in developing countries, which leads to maternal and fetal death. And lastly, it's continuity of care. I think Australia, UK, any midwife-led system has always been very, very strong on the fact that we need to allow the same doctor, midwife to actually follow the patient through her journey, because that gives her reassurance, that reduces anxiety. And through our platform, what we're looking at doing is being able to supplement in-office touch points with digital touch points with the same clinicians as well. And the same clinicians get to review the data, so they're much more familiar with the patient when they come to labor. And again, decision-making clinically is better when you have continuity of care. Anxiety of women generally reduces. And so, hitting those 3 pain points: access to healthcare, consistency, and continuity of healthcare.
Yes, and you bring a valid point in a sense that there's no place on this planet that that haven't been through a stress test right now with COVID. So, and no matter where you are, so some pregnant women have been through some critical times with COVID. So, indeed, and now I think Harpreet, on the side, you've also touched a bit on some of the pain points you saw. What have you saw, and what are you still seeing? I would say that are some of the pain points that need to be addressed here with some of the...
I think both Enda and Amrish have touched upon the accessibility and availability. For me, I will say, like, to add on what they have already conveyed, the realization always is, as a technologist, you go after the problem and you try to solve, and you think like, technology will solve the problem, but actually it's not a technology problem. It's a fundamental governance problem. So it's not like, why we are losing so many babies in Indonesia or India is because there's lack of technology. These technologies are available in the Western countries and they have clinical outcomes. But as Amrish pointed about the accessibility piece, and by that accessibility is not being available, is usually, end up as a commercial model, because ultimately the businesses, in our case, the enterprises like the hospitals, they are always under the stress of increasing the customer revenue, and primarily, either we are government paid systems or patient paid systems, and not insurance driven systems, especially in the developing market. So the commercial model of enabling your technology so that it appears to increase the revenue model or revenue for the hospital becomes a bottleneck, because fundamentally you are, as an entrepreneur, trying to solve a problem, and you're not trying to solve the business case. So you go after solving the problem and do it very well, and then you realize that no, this was required from from an opportunity point of view, but the real problem is how to fit that into the business model so that it makes money for your end customer, so that you get paid. and usually you don't get paid because they don't get paid by adopting new technology. So I will say that appreciation comes when you go into the field and you try to say that, oh, you want to reduce mortality, but you can get a response that why can't you have a second baby? If you lose one, why don't you have next one? Because giving births, you produce so many babies in the country, and that's like, for you, it's a funny answer, but I heard it from so many institutions. So I will say that commercial translation is one, and then the second is the I will say, to add, you have all these individuals or the thought leaders who will like to jump onto a technology, and they will like to work with you and show that this technology works, but their motivation of sticking with that technology in terms of bringing it to their actual workflow is not the motivation, because they want to jump to the next technology in 6 months or a year time. So it never reaches to the ultimate user, because that discipline of converting it and bringing it into their workflow and bringing that transparency is not the motivation, because unless that's not there, and both these points, I will say, in the developed market, I don't see those challenges, because the governance to motivate the benefits from insurance side, enabling digitization, empowering hospitals who want to bring more transparency. So you try to solve those issues so that technology can be consumed. But I will say those are additional points to the points which Enda and Amrish have already highlighted.
Thank you so much. Yes, indeed, I think that there is many pain points that remains, right? Simply because not everyone's aligned as well on solving them. Thank you, very, very good point. Now, guys, I want to ask you, I think, a question that is always something that we hear when we speak to different stakeholders and in our network. So, do you have some data to give us? So we definitely know that all of these digital solutions, especially yours, when we understand what you guys are doing, we know that it's really helping, the women, the children. It's helping the doctors, the midwives that are working with them, or even post-pregnancy, what all of the work that has been done. And Anda, you started to touch on that. You actually collected some of the data that you know that you've been saving lives. Can you come back a bit on that point that we started to touch on, so that our audience understands the impact of your solution?
Okay, as mentioned earlier, it's one of why maternal mortality rate is high is because it's the late detection of the risk factors, and that is actually what our solution is trying to do. We do early risk factor detection. So like in Indramayu, we help 200 mothers within their second trimester from having anemia to not having anemia anymore with the right intervention based on the data and based on the journey of continuous care, like Amrish said, because we always monitor them. What is the risk factors? Has it been lowered, or the right intervention has been given, and everything. So within 2 months, we help 200 mothers from having anemia to not having anemia, which at the end will potentially save them from having postpartum hemorrhage or lower birth rate in the baby. We actually with the solution, we also help midwives, because like in Kupang, it's in the east part of Indonesia, where to do a referral from a community healthcare to a referral hospital, it could take like 3 days. You have to go across like 118 rivers, because I've been there and we work there as well. So we have managed to increase I have to look at the data. We have managed to increase the early referral by 62%. So it can help the mothers actually to not being late to be referred to a higher standard healthcare facilities. And we help them to detect risk factors earlier by 88%. Because like in Kupang, in East Nusa Tenggara, there are times, about 6 months, that they don't have an obstetrician. So they only have midwives. So all the interpretation from there is sent to our consultation center in West Java. So it's our obstetrician who help to interpret the result. As Harpreet said, this is not only about technology or the competence of the healthcare workers, but actually the regulation and the political will of the government plays a big part in making sure that technology will succeed in bridging the gap of healthcare access and everything. Because especially in Indonesia, healthcare is a highly regulated industry, and the government has to have a political will in that. Well, in Indonesia itself, there are around 5.4 million pregnancy every year. With this COVID, it is predicted to increase another 4 millions of pregnancy. And I think India is predicted to have another 10 million babies next year because of COVID. I know it's quite worrisome if the quality of the maternal and mortality outcome is not being upgraded. I mean, we're going to have lost generation and everything. It's going to be a burden for the world as the earth is also growing older. And in Indonesia, if I may say, there are 2 mothers died every hour because 2 mothers died every hour because of in labor, and 7 infants die before the age of 40 days.
Yeah, and that shouldn't be, right? In the world that we live now, that shouldn't be.
Yeah, it actually can be tackled with early risk factor detection and complication management.
Exactly, and I think this is the data that you gave us are fantastic, because I think now it really helps people understand that there is a true positive impact when using technology the right way. Yeah. Thank you, Anda. Yeah. Same question for you, Amrish. I mean, let's talk a bit of data. So you certainly have a bunch to share with us. Let our participant understand the impact of your solution and what you guys have seen.
So, I mean, what I can comment on is a number of these studies are ongoing. So, I mean, I can give you general trends of what we're looking at right now. And I think in the markets we're in, Europe, Australia, Singapore, potentially the US, what we see is there's an intersection between clinical outcomes and cost. Because in pregnancy in many of these countries, we have actually almost optimized for some types of pregnancies, the outcomes. So they can do very high cost monitoring interventions. And we need to know how we can justify this. And so the partners we're working with have actually shown that they can detect hypertensive disease earlier in Belgium. In the UK as well, it's reducing the number of visits required by the woman into hospitals, thus reducing her risk of in-hospital infections. And even by 1 or 2 visits in the 3rd trimester, even. And we're looking at the fact that some of the protocols we hope to implement around the world. And the benefit of a system like ours is that we can implement these protocols through our virtual visit program. And we can take best practices from clinical trials around the world and implement those in other areas which have not seen those protocols yet, even in developed countries. And for example, growth-restricted fetuses, we can reduce the mortality rate and the cost of managing the disease as well. And these are significant savings in cost by more than half, as well as the mortality rate as well. And so what we're looking at is that intersection of effective care. Singapore has one of the lowest stillbirth rates in the world, but we spend so much on healthcare. And is it really necessary, and is it really effective? We spend 80% or maybe of our pregnancy budget on the 10% of high-risk cases in the UK, Australia, and Europe. And so it's very, very key to understand that now we're at the edge of how do we improve clinical value, how do we maintain, improve some of these morbidity rates by a little bit, not as much as ANDA will be able to in Indonesia, certainly. But the goal here is how do we build cost-effective care? And I think that's very important for a sustainable healthcare system. Considering pregnancy is not a disease to begin with, I couldn't stress this hard enough. So, and so, yeah, I think that's some of the data we're seeing. And I mean, what we hope to achieve is actually choice in terms of number of visits, where the data can be augmented by out of hospital or amplified by out of hospital monitoring. Reduction in some parameters for high risk babies, mortality included, and finally effective costs so that more women can access high quality healthcare. So that is the basis of what we do, and that's some of the data that we have at the moment.
Very good. Thank you so much, Amrish, for sharing. Very good data, indeed. And Harpreet, on your side, what kind of data can you share with us on the certainly positive impact of your digital health solution?
Yeah, so for us, these are three different markets we cater to. I mean, we work with Indian market, Indonesia market. We have installations in South Korea, ongoing installations in Singapore, and then we work in the US market. So I will say, as we started in the developing market, the data focus was how much digitization can you bring in, because neonatal ICUs traditionally across the world are paper intensive, because there's no solution which can bring in all the information coming from digital devices linked with EMR and do all calculations. Because in our case, the baby is as small as 400 grams. And if you give him more than 5 ml, it's like it can cause infection and you can have bleeding. And there's no feedback mechanism, because 24-weeker or 23-weeker baby will not tell you. So there is no response system. So for us, the first impact was how much can we bring in terms of data aggregation and data standardization. And that was the first impact, wherein aggregating all devices, including the blood gases, patient monitoring, ventilation, warmers, incubators in any intensive care unit, that gives you 70% of digital data, which is getting right now missed, because the EMRs traditionally link with one or two systems, but not from all vendor agnostic systems. So that was, I will say, our first win in the initial year, where we were trying to emphasize when we published studies that we can get timeliness and data quality in terms of data completeness. Mostly in the developed markets, they already have solutions where they have tackled this problem, because they already have digital data, maybe not from all sources, but so they are trying to solve incomplete data problem, but the focus is optimizing length of stay, because each day of stay in US can be $6,500. So if you can reduce the baby stay, you reduce the chance of nosocomial infection, so the baby gets less infection, and the financial as well as the anxiety for the parents get reduced. So the other reports where we focus, or the peer-reviewed papers which we published, was the impact on length of stay. Can we at least show 15% reduction by following the guidelines? Because NICUs or neonatal intensive care units are 95% technology and very little clinical care, because the baby doesn't have lungs are still growing up, so you have to give a lot of CPAP, ventilation. The baby is still developing immunity, and brain development still happening, so you are relying on the devices to keep the baby alive. So you have to go with what the guidelines are, and you have to follow the discipline. The third sort of studies for us is early detection, as Amrish also pointed out. I mean, there was enough literature on using like heart rate variability, using different physiological data to predict diseases like sepsis or bronchopulmonary dysplasia, things which are very common in NICUs. And as any other group, we have to also present that our analytics can do 95% of early prediction. But I will say that's more to stay in the game. But the real value of a decision support system is always about supporting the clinical team. So finding those cases where the doctor has missed and bringing impact in those cases and trying to save that baby, that's a very hard problem. And you can never take the credit because it's ultimately the clinical person who is watching the baby, and you're providing that delta to that person. But yeah, we have done our sort of publications to show that, our system works. But ultimately, the impact of how many lives, that's an ongoing problem, and we are also improving in that.
Yeah, thank you so much. Fantastic. Indeed, important data to save these young lives. We are having a question from our audience, and that's actually a question I wanted to ask you guys. Let's talk about the technology adoption, right? So it's Pratik Joseph who's asking us that. So basically, right, such as what are the health workers, right, the midwives and the educators, the doctor, how do they overcome some of maybe the use of your technology, right, the barrier to adopt your technology? What have you seen have been some of the challenges, the actual use of the technology? Can you tell us a bit more about that? Is there some challenges? How do you overcome those? And maybe again, I'll start with you, and to just maybe share with us what have you guys experienced, and how does this unfold for you?
Of course, technology is something new to most midwives in Indonesia. It's actually, we are teaching them the digital literacy through this actually, and it takes quite some time to get them to get used to using the application. But that's why we create TeleCTG with its own, with the probe that they are already used to. So it really cutting the time for them to adapt with the technology. That's actually why we come up with the design of TeleCTG, because we don't have to teach them a new kind of sensors. They already used to using such kind of sensors. And actually, we have, well, we might say that we are quite successful in the digital literacy, because like in Kupang, with COVID, actually, we started to transform all the offline activities into online. So we do all the training of the apps, of the TeleCTG through online. And usually it takes us around like 2 hours to train midwives to use the application, and 1 hour for and 1 hour for midwives to use the device. And it works well. With that, actually, we have cut down the cost of medical device distribution cost, because actually all the offline activities that usually quite expensive, because we have to go to the site, and now we don't have to. We just do it online, and actually it's quite well with our in our experience, because we have operated with the application, we have operated in 34 provinces of Indonesia, and because we also have a online training as well. Yeah, we started to teach the midwives in our community to be not digital savvy yet, but digital literate. And actually now what we do is we train the midwife coordinator and let them retrain their subordinates. So in terms of adoption, yes, it's quite challenging at first, but it can be done. So
thank you. Yeah, very interesting in the way that you guys are trying to support all of the users of the technology. Thank you so much. Amrish, same for you. So your technology is being used remotely, right? And so what are the feedbacks you've received, or some of the challenges you guys face, and how have you overcame some of these challenges? Oh, I think you're on mute.
Unmute first, yes. No, I mean, first of all, I think the biggest challenge we faced was mindset of what could be done remotely. And I think it's something that we really needed to overcome. And that was something we tried to overcome before the technology part of it. But I think it's also, now that everyone's hot on telehealth and telemedicine, is understanding what telemedicine should really be doing. It should not be replacing all in-person visits. It should not be, entire substitute for care. And I think with that in mind, what we've done is we've redesigned the systems for fetal heart rate, maternal heart rate from ground up, assuming users with no practical experience in the field. And this serves us for multiple reasons, in that women can use it at home who are non-clinical professionals. If eventually we do go into developing countries, it allows for a model of community healthcare, not just midwives, so it can extend into community health workers. And so fundamentally changing the usability of the device to suit the user risk. So the user profile must be taken into account here. And I think it won't have so much of a problem of familiarity, because if it's easy to use, it's easy to use. And I think if it serves that function, that's all it needs to do, provide the data that they need. And so I think that's why it's important that we consider the end user and redesign the whole system around the end users. And being able to display, being able to give them simple feedback. I think Harpreet touched on this. What is that feedback loop into the women? And what data can we give them such that they are not anxious? So we're not going to give them fetal heart rate data, for example, because that is uninterpretable to a layperson. And that's going to cause more anxiety. That's going to cause false reassurance. But rather we give them blood pressure trends, where, it's a lifestyle management thing. And it's about how do we make this data useful to the different stakeholders, to the clinicians, the midwives. We're going to provide the full spectrum of data. And that's how we see it as trending information, which is much more valuable than cross-sectional information, than just information in one period of time. And again, it allows for better clinical decision-making. So it's really about starting from the ground up and not adapting a hospital system to home. That's not what it's about. So I think that's been very key in our design philosophy from the start. So addressing that, it may come at a slightly higher price point now because we've redesigned the system and it's custom, but as it progresses, it can actually be reduced even further as we get economies of scale, as well as we develop more components on our own. So that's how we're addressing it through the technology.
Very good. Thank you, Amrish. Harpreet, on your side. Yes.
Yeah, so that's a very interesting question, what Prateek has asked. So currently we run close to 300 plus NICU beds, and each unit for us usually costs, like it's a high-end hardware which combines data from different devices, cameras, to make it real-time accessibility. For us, the patient is still not at home, so it's not telemonitoring. The patient is still in the intensive care unit, and with COVID, the doctors are still so there's a lot of issues that the doctors and nurses are getting infected. So the accessibility to the patient, even when the patient is in the hospital, is very hard. But I mean, this is one of the concern as a founder or as an entrepreneur. If anyone asks me, like, what's the biggest reason the company can fail, is the high cost of equipment, the COGS, and one of the questions, because we sell our equipment on subscription model, both in the developing and the developed market, and we do a 5-year agreement. As Amrish has already responded on the group, just to show that it's a year-by-year revenue, and with a 5-year lifetime value, the investors and the board is satisfied that there is a return on the initial investment. But still, the question always remains that in technology world, customer can make a decision and leave after 1 year, and you can have all the legal contracts, but there's an investment which you're doing upfront. And with the way technology is moving every day, we have new GPU chips, you have new boards which are getting cheaper and cheaper. So you can always go to technology of scale and reduce the cost, but that's available to all competition. So, I mean, what we have done is we continue to try to go with volume that, we go from 300 beds to 3,000 beds, but that means we also need more investment. We have to raise more money, where less money is going in cost of product development, but more money is going in deployment and getting more data. Because unless we don't have that data as a deep learning or a technology company, analytics company, we cannot prove that our solution is bringing impact. So it's a catch-22 situation where you have to invest and generate more data to bring more adoption. But at the same time, there's no easy way out. I will not say this is a developing world, country problem versus developed country problem, because you want to deploy more in developing country to get faster data, to be more prepared for a regulated market when you get into the developed market. Because if you have issues in the developed market, the medical liabilities are much higher. So you want to play more in the developing market, and that was our strategy of getting into Indonesia and India first, and before getting into US, because you only get one opportunity in these accounts. So and even in the US, it's very hard unless you don't do IRBs and don't do proper clinical trials to convince the customer. So it's not like they're willing to pay for it day one. So I don't have a very easy answer for this problem, and that's a constant problem which we are trying to justify.
Thank you, Harpreet. It's the only time we have, but if you don't mind, guys, I'm just going to ask you one last question. Maybe you can answer in 1 minute so that we can wrap this amazing panel. I mean, the particular segment in where you guys are operating, whether it is the pregnancy, the post-pregnancy, or growth development, brings a lot of anxiety for parents, women, mom and dad. Everyone is, even the family around, brings a lot of anxiety. Are you guys capable of kind of capturing if there's kind of a moment of distress in a woman during the pregnancy or post-pregnancy? Is your technology being able to capture that? As we know, usually the doctor will see or will kind of capture these signs face-to-face. What about with your technology? In quick 1 minute, maybe one of you would like to explain that.
So which one has to explain? I think this is going first.
You want to go? You want to go
ahead.
Yeah.
So yeah, I mean, it's a see, COVID has been a big help for us. I will say it's a very bad statement to make, but for a digital telehealth company, it has done the sales job which as founders or as entrepreneurs or as a big sales team cannot do. I mean, we get now more requests where customers are keen to use our technology to manage their patients. But again, it's a big area of whether we are able to solve stress, because as soon as you use word stress, there's this regulatory impact on you. So we never say we try to measure stress or anxiety, but yeah, the it's more like a feedback when you're using telemonitoring. Are you satisfied by the quality of video, the quality of data? And as a clinician, are you still able to make the same clinical outcomes? As parents, are you still able to get the same warmth and feeling which you can have when you're physically being with the baby? The clear answer is absolutely no. From a parent perspective, I mean, from a doctor perspective, I will still say as long as the outcomes are clear, they can say that they're still doing the good job. But as a parent myself, the comfort of being next to your child versus seeing your child from home are very two different things. And even you want to do that, but we ask in our app after they have done the remote viewing of the baby on a scale of 1 to 5, how comfortable, and if they want to give feedbacks, we improve that in the application. But that has been allowed because of COVID. It was not, I mean, a lot of leverage which I have received in last 3 months. The contracts movement which has happened in last 3 months was not there pre-COVID time.
Thank you. Quickly, Amrish, on that?
Yeah,
yep.
Because we work through midlives, it's actually our solution give the comfort and confidence in midwives. So because they can consult directly with the obstetrician, so they can give more assuring answers to the mother. So from like Harpreet said, directly to parents, yeah, maybe through the risk factors detection, but we can help to empower midwives and make them more assured and empowered, as well as confidence in doing their job. And I think that it will transform to the mothers. I think that's my answer.
Yeah, thank you. And Amrish, the last word of the day. Not so bad, eh?
No, but I would first like to say I'm completely inspired by the work Harpreet and Anda do, and it's really good to see all of us in the similar field coming together and sharing ideas. But I mean, mental health would be the blind spot of most telehealth systems, I would say. Everyone's focused on vitals, everyone's focused on all these sorts of things, and like Harpreet said, nothing can ever replace the touch or the in-person interaction. But I mean, what our system allows to do is actually screen, and I think that's the most important thing. And where the doctor senses or where the nurse senses that there's help needed, then they can bring the patients back if necessary. And that's what telehealth should be. It should be a screening tool to assess who really needs to go back into hospital. And I think for us, that's it. And you can, there's several validated questionnaires like EPDS and stuff like that for anxiety, for depression, which can actually give you decent scores at certain intervals during the pregnancy. And so, like I said, it's not going to replace anything, but what it helps do is highlight the patients who need help the most. Exactly. And that risk stratification is really what telemonitoring is all about.
Perfect. Great, great last word. Thank you so much for joining us today, for really giving all of your insights. It was really, really amazing to have you, the three of you, during this last hour. Thank you so much. And now